Hi, good morning. In Italy is 9 p.m. and good morning. Welcome to the all patient in connected by in another country. I am Dr. Stefano Galli from Italy, and I am interventional cardiology. And now I introduce the other colleague, Professor Fu from China, that is my co-moderator. And now I share my screen. Can I share my screen, please? Okay. And now I introduce the other people. Okay. Myself present the case-based evidence of device for PCI tip and tricks. After me, clinical experience in using cutting balloon for resistant lesion, Dr. Zhanying, scoring and cutting balloon for optimal lesion preparation, Dr. Helen Routledge, and balloon for uncrossable CTO, how should I do, Dr. Krissada Meemook, and why I shifted to scoring balloon, Professor Hussien Heshmat. Big panel, fantastic guys, and remember that Professor Fu is a moderator with me. Now we start with the first presentation. Okay. Case-based evidence of device for PCI. First of all, POC technique to optimize PCI in bifurcation. You know very well the POT, prox optimal technical optimization technique, is mandatory in bifurcation PCI. But technical aspects are crucial to correct POT and rewiring. Normally, the standard balloon in terms of conformability, length, and shoulders have some limitation. And don't forget that we use a POT technique proximal, but sometimes we need to use a distal optimization technique when we have a difference. This is a typical example. In the left, there is to move a lot the carina. In the central part before the carena, we need to correct precise to avoid the carena shifting and the plug shifting. Also, distal optimization technique is very important, especially in Medina 010 lesion or in tandem bifurcation. Or there is a big discrepancy between proximal or distal to collateral branch dimension of the vessel. First of all, we have some limitation of the NC balloon. The pod balloon give to us the possibility to have a very, very short shoulder to apply the force exactly in the point that we need to optimize the result. There's also, it's very important if you want to use this technology for pot side pot for provisional stenting technique, or it's important. This is a typical case. We have a discrepancy between proximal and distally. We put a stent, we predilate, put a stent, and then we use a pot balloon proximally to optimize 3.56 millimeter, and distally another pot. And you see very well how we respect the conformability of the vessel, saving the ramus, and also we also possible to do a crossing and a reverse kissing pot. Obviously, pot technique in two-stem bifurcation is mandatory to a different type to facilitate the rewiring and to open very well. This is a typical case where there is a big discrepancy between the main stem and the branch LAD and circ. And you see the images. You see the wiring of the circ and then the wiring of LED, and then we prepare with a Mars semi-compliant balloon 3.0 15 millimeter, the both branch. And then this is a Mars balloon. It's important double layer balloon material, provide the superior high pressure resistance. It's very important to in this case. In this case, it's very important to choose the depth at the opening cell angle and the area of the cell. This is the implantation technique in bifurcation decay culotte, and we put a stand, you do a pot, first pot, and then we rewiring the vessel. You remember to you that a lot of passage of this technique. After pot, we recrossing, and also we recrossing with a small balloon, and then we reopen. You see very well, sometimes it's not easy, but after the pot is more easy to cross. And then after crossing is possible to deliver another balloon and then another stand. After the stand, we redo another pot with the same balloon, and you see it's very easy to recross after pot, and then we finish with the kissing balloon first and then another pot. This is a final result, and also this is a result by IVUS that confirm how to use this technology. It's very important. This is another situation where it's very important to use the pot technique to rewiring when we have difficulties in terms of angulation. And after mini crash, we recross very well, we finish with pot, and the result after 3 months remain very, very well. So I believe that is another tip and trick. Now we move to uncrossable lesion. Sometimes we have a lot of things. This is a typical case of recurrences of ISR, and we fail. We try with a standard balloon. We use a alveo high pressure 0.75 progressive dilatation. Then we insert also the Mars and C balloon, but remain underexpanded, probably due to the calcification outside and the material. With this is a alveo technology. Then we probably see in other presentation. And with the probing the guideline, we advance a laser 660, 8080, and 8080 pure dye injection. And after a multiple irrigation, is possible to cross with a DCB balloon and finish alveo, NC balloon, laser, and then NC balloon and DCB. And this is a result after 14 months. I believe that it's a good result. But all start to cross with device. It's very useful in this case, alveo strategy. This is another situation, very easy. The patient have recurrences for angina. You see very well the pinching of the diagonal, and you appreciate a double layer of stent. It's difficult to cross with semi-compliant balloon. You see very impossible to cross, but then we use alveo, and alveo cross very well. You see in the stop imaging, and then progressively use a lot of things and finish with drug coating balloon. This is a final result. I believe that is very simple, but if you have on the in our lab the device, it's used for us. And finally, I want to share to you the Revo Edge, the last new of BrowseMed, and I don't want to use a lot of time discussing the result, but this is a 6 point where probably the Revo Edge is a technology that we apply. What is Revo Edge? Revo Edge is a combination of, first of all, NC balloon is possible to go to 20 atmosphere. Second, the wire is not attached like a blade of the cutting balloon on the balloon, but it's free, is attached only at the shaft of the balloon, and it's possible to increase the crossing profile. This is for a first example for the calcific lesion, severe long lesion in proximal mid LAD, wiring the diagonal and LAD, and then we start with 1.5, 15 millimeter in length at 20 atmosphere to prepare. You see very well the different dimension of this balloon. And then we move with the 2.5 20 millimeter rainbow edge, and you see very well the different cutting wiring, and then we post dilate with a NC balloon 3.2, and then this is the result after preparation. Could you see the controlled dissection? We have no a long dissection. Obviously, we apply the force in multiple points, but I believe that's important to have a force where we need. And then we put a stent, two stent, and we respect very well the branches. This is another case where we appreciate the high performance of rainbow edge, diffuse lesion, and calcific. We cross with doesn't cross IBUS and cutting balloon. We use in the standard balloon, and then we advance a little bit the rainbow edge. The rainbow edge don't cross completely, but we engage with the tip of the balloon, the lesion, at inflate, and then you see the crossability, the performance with cutting balloon show the big difference between the two technology. And then we push a little bit, and we able to advance distally, and we do a lot of dilatation. You see very well the conformability of the calcium, and then after the rainbow edge, we use a NC balloon, and we finish the result in this situation after preparation with the NC balloon, with the drag coating balloon, nothing left behind, and we don't put a stent in this situation. Another simple situation, but I believe it's important, is a fibrotic lesion. This is an osteal lesion shown, obviously not difficult, but it's very important to avoid the slipping of the balloon to don't damage the distal edema, especially the left main. And you use a focal rainbow edge in this point, prepare very well the lesion, less than 20%, and then we put a stent, and this can you appreciate. Obviously, it's very easy, but it's possible to use this technology to prepare, especially the fibrotic, also the fibrotic lesion. We advance and we go at the end of my presentation. CTO, a small vessel, we cross in the Gaia nest, we check the distally, and then we prepare with 1.25, and then we use a rainbow edge to modify the plaque, multiple dilatation, 2.0, 20 at 20 atmosphere, and then rainbow edge a little bit more, and then NC balloon. And this is a finally preparation of of combination of rainbow edge and NC balloon in mid-distal portion of LAD, and we finish with the cutting balloon. This is a final result. I believe that is another application of this device in this situation. And finally, another tip and tricks. We have a combination of restenosis and you don't see very well, but there is a tight lesion in very old ISR in BMS 10 years ago, and progress of the lesion. We try to advance a rainbow edge, but doesn't cross, and we inflate the balloon in the proximal part, probably due to the dimension of the rainbow edge, but also for the friction of the rainbow edge. We prepare rainbow edge before, and then we can appreciate the differences between the rainbow edge and the cutting balloon, especially when we inflate the previous OG balloon. We completely have the shape. The shape is completely different. And then after pre-dilatation in portion, you see very well that the rainbow edge cross very well until distal ISR. And can we prepare very well the ISR inside to the stent? You can appreciate the focal dissection, a control linear dissection that we fix distally with this DCB inside to the previous stent and with a new stent in the proximal portion. And the last case, the bifurcation in stent, it's very tough case. Patient with 20%, 25% of ejection fraction and complex patient. And we see very well the probably underexpanded stent. We cross with the short balloon in the diagonal, and then we advance the revo edge until the mid portion inside to the distal stent between the two stents in the proximal part, and you fix the dissection with the stent between the two stents with the DCB until the proximal to avoid all metal in the proximal ostial LAD, circ, and left main, because we prepare very well the lesion with the 3.5 revo edge and finish with DCB. The result the result is very good. Obviously, we go rapidly because we need to move to the other presentation. In the typical case of the tough lesion, recurrences of the ostial circ, you see the IBUS, a lot of material after simple balloon. We use the revo edge a lot of time, and then we drag coating balloon and remain plaque, obviously, but the cutting of the tissue and the modification of the tissue inside to the stent give to us the opportunity to gain a good lumen, to avoid other stent, and to use the new technique. Thank you for our attention, and now we move, if you want, to the discussion. Thank you.
Yeah, thank you, Professor Galli. It's really nice, really good presentation. It shows us a lot of really complicated cases, and use very the new innovation balloon and other technique to solve the problem. Actually, you know, the atherosclerosis is getting more and more severe, and patients are getting older and older. So the cases also become really complex and really high risk. So we need some very special technique, special innovation balloon to solve this problem. It's a very nice lecture. And we have several others are online. So do you have any question or any comments on this topic? So, Professor Galli, the last innovation balloon called level EG, it's kind of a double wide balloon, something like that. It's I think it's some company from Singapore. They have I'm not sure which name, a very niche company. As they have it, and you are different, as it seems.
Yeah. So I believe that the revo edge is, for us, it's very important. In Europe, we have a tradition of, not only in Europe, of the cutting balloon, Wolverine, but obviously there's a different technology for two reasons. Normally, sometimes the correct use of the cutting balloon is 10, 12 atmosphere. With this technology, it's possible to go safe until 20 atmosphere, first point.
20 atmosphere. 20 atmosphere.
Important, because if you use the cutting balloon more than 12, 14, the risk to coronary perforation is not so low. Second point is the independent wiring is not fixed on the balloon, and is better to refolding and also reopening to recross a lot of times. Sometimes if you use a cutting balloon, we cross, and then if you want cross another time, it's not possible, especially in bifurcation. And if you know the technology, like to explore before regarding the scoring technology, it's similar to scoring because we go with wire. If you see the case with the LAD and diagonal, I have a 2-wire, and then I have another 3-wire around, but we cross very well. Another important point is the dimension of this technology, 1.5 and 2.2. I believe that probably a part of the cost, okay, but they probably a new idea. I showed to you the idea to a progressive diameter preparation, 1.5, 2.5, and if you need 3.2 and more. But this is another important concept. Normally, we don't use this concept in the cutting balloon because we have only 2.0, but is the profile is similar 2.5. So this is a technology that reassume in one device high pressure, independent wiring, and cutting.
Yeah, so that's good. Yeah, so the crossability is much higher than the cutting balloon.
Yeah, this is the point of cost is important, and I believe that the company to move in this direction. Absolutely.
Good. Thank you. So, any comment? Good. So let's move on.
Move on with the another presentation. Okay, please, Dr. Zhanying.
Okay, and just now I have noticed and Professor Galli and presented have shared with us many and very challenging cases. Now and let's move to share my slide.
Okay, when you want, you can start.
Okay, and can you see?
Yes.
Okay. And good morning, and Professor Galli, and good afternoon, and Professor Fu in Chinese afternoon. And so let's start to share my case. The topic is use of novel cutting balloon. I mean, there may be the third generation cutting balloon, and before DES and DCB population with high resistance lesions. And I'm Dr. Han from China, the professor of Physics Hospital of Zhengzhou University. And, okay, and several days ago, and one 63-year-old female patient and had been admitted to our hospital for chest pressing exertion for 15 days. And the physical examination reveals this patient have so many abnormal risk factors, and the blood pressure is okay, EKG is okay, and CG. And this patient has been given the angiography for 2 days ago into the echocardiography. It shows demonstrably normal. And the risk factors is this patient has a history of diabetes for 20 years. As you know, this one is the laboratory investigation into the troponin T is relatively high. So this EKG demonstrates normal, and we diagnosis is coronary disease and maybe NSDME and PCI. She has PCI in other hospital and diabetes too. And this is just give the commonly used medicine like the aspirin, clopidogrel, and such as others. So I'll show the result of the angiography, and from the right radial artery, you can see it's a right coronary artery. For this patient, you can maybe, I think you have noticed the proximal stenosis at proximal segment, and its diffuse lesions and total occlusion at the distal part of the this part of the right coronary artery. I'll show you from the another view. You see this one, the PLA is total occluded. The left coronary artery shows diffuse calcification lesions at the proximal A1 and for this one, and see it's lung lesion. Right for the circumflex is total occluded too. You see. From spinal, you can see the orifice of the circumflex is very serious stenosis. It's the orifice osteocircumflex. See here. And from the right left coronary artery into the supply to the collateral circles to the collaterals to right to the PLA here. So the RCA shows diffuse lesion and occluded distal lesion for the PLA, and the LCA shows diffuse and calcified lesion. So what's the strategy for this coronary artery disease, and how do we choose the strategy for revascularization? Maybe the CBG and PCI conventional therapy. Of course, you have no result. We have chosen the PCI for this patient because melanoma patients in China or in Asian and all of them, melanoma patients refuse the CBG. They more prefer to choose the PCI strategy. So the targeted lesion is the RCA, which then guiding passage, the cell, and the PCI guided by inverse, which is a balloon, NC balloon, and a cutting balloon, maybe shockwave standby, stand, DCB. It depends on the operation procedure. So the guiding passage, because of this is a small lady, we choose from the right radial entry route, which we choose a 6 branch cell 0.71 for this patient, and assisted by the microcassage, and we choose an XTA and to successfully cross the distal occluded part, then in change to Xiang guide wire. First balloon is 1.5. So it's then into this balloon diameter is 0.2. This one you can see it is the proximal segment of the right coronary artery. You can totally inflate the balloon, just like this point. So after the predilation, using the 2 balloons, let's see, it's a recovered flow to the distal part of the right coronary artery and to the PLA femur. So the lesion is too long. So what's the strategy used? Then we choose the cutting balloon. This one is Reno 8 cutting balloon with this new generation novel cutting balloon, and the characteristic has been introduced to us by Professor Galli. So it has a 3 mark. This one. So maybe we have noticed it's relatively difficult to advance this cutting balloon to the distal part of the right coronary artery. So I have just inflated as the program here. Then after treating the proximal segment, we choose another NC balloon to predilation here segment, the middle segment. I'll show you how to advance this cutting balloon. After predilation with the NC balloon into the distal part of the right coronary artery, we will successfully advance this cutting balloon to the distal part. So this case is not so complex. So this is a target, and this no valve cutting balloon, we have noticed its length it's about 15, and at the same segment compared with we commonly use the cutting balloon in market. Usually it's for the compared the other cutting balloon, and the length is 15 because they have 3 segments, and this mark point, this mark point, but this cutting balloon has only 1 segment. So, and it's very easily to advance it cutting to the distal part. So after the predilation with using this cutting balloon, and perhaps if the IVOS check because of the time read, I'll show you first. You can see this one. Then after the predilation, what's the strategy for these long lesions and perhaps not so serious calcification lesions? I think that according to our center's experience, you're choosing the DCB and combination with the DES, the hybrid strategy for the right coronary artery. It's for DCB. The first DCB is 14 millimeter, and the second DCB is 20 millimeter. Then at the segment, middle segment of right coronary artery, we choose the 1 stent. Oh, the length is 34 stent here. So post dilation, normally check the IVOS again. It's right. The final result. So after 1 week, we and to treat the left coronary artery for this patient, I'll check the right coronary artery again. You can see it looks good for the result of the right coronary artery. And through right radial artery, we choose MC as XTR into open the circumflex. Predilation for the LAD NC balloon, and we'll show you first. So our question is, how about for the proximal segment of the LAD? Let's see. For R phase, that's the predilation. For the R phase of the osteo circumflex. using the DCB to treat osteocircumflex. The final result, we haven't treated the proximal segment of the LAD, just implanted one stent for the middle segment of LAD. And the blood flow is okay. And we check the errors. It's about nearly 3 millimeters square. And for, I think, according to the guideline for vessels, LAD, especially for the LAD, diameter is less than 3 millimeter, then the area is 2.4 millimeter square is okay. So we didn't treat because of this patient maybe his clinical symptoms has been relayed. So the discussion is a renal 8 cutting balloon, and this balloon has very characteristics of better crossability and the thickness increase 30%. And the outer diameter is very small. Fragment is because of the nitino, so the flexibility is has been improved, so, especially for the higher rated burst pressure, 20 ATM. So I think it's very good for this new novel cutting balloon. And take-home message for patients with high risk and complex lesions, maybe we choose the novel cutting balloon, maybe has better crossability compared with others. A hybrid strategy using DCB in combination with the DES is simplify the procedure of PCI. For this patient, maybe the rotor cut guided by IVI intravascular imaging and FFR may be an option for this patient. The use of novel cutting balloon with improved crossability may bring benefits to the operator and patients with complex coronary artery disease. So, thank you. This is the end.
Thank you, Dr. Zhanying. It's a fantastic case. They demonstrate how to cross. And I believe, honestly speaking, regarding my comment regarding the RCA, probably in the after Revo Edge, in the portion of, especially the portion of DCB, we go more aggressive and see balloon. Nevertheless, the result after 1 week, it's outstanding. And probably if you want to use a more aggressive Revo Edge, so if you want to prepare very well the lesion, we move to 3.0 Revo Edge or 2.75, especially in the mid proximal LAD and in proximal but I appreciate a lot how to this technology could help us to prepare very well the lesion, especially if you want to use a combination of hybrid procedure like you use DES and DCB. Thank you for your case. But another comment of this. I want underline one point. If you appreciate into the case, especially in the RCA, the use of the probing catheter, remember the compatibility. 3.5 more than 3.5 Revo Edge, we need 6 and 7 guideline or probing. For the other, the standard 5 and 6. It is very important because if you use a 3.5 Revo Edge in probing compatible with the 6 French guiding catheter, doesn't cross. Perhaps some question from the audience, or Nancy, we reach some question, or Professor Fu, from the participant in the chat line or not?
Yeah, it's a very interesting cases as Dr. Han has presented for us. I think it's Prof. Hans is from the largest hospital in Asia. He did a lot of experience, especially in the drug coating balloon. And his supervisor, Dr. Chu, did a lot of experience in de novo lesion, used the DCB. And for these cases, I think it's really successful, pre-treated with cutting balloon and get very good immediate results. So use the DCB. It's a very nice choice. I think especially for patients, and it's very good. I have a very, very small question. I noticed, Dr. Galli, you use the cellulimers coating balloon a lot. But in China, we have the cellulimers balloon just beginning on the market. So what's your comments about the cellulimers balloon, coating balloon, and paclitaxel balloon? Do you think which one will have very bright future and which one will become the main tool for our clinical practice?
Okay, thank you for question. Two rapid answer. First of all, I believe a lot in DCB in de novo lesion, but especially in the vessel less than 3.2, the result is very, very hard. Now we wait the TCT data from the larger vessel, but regarding, we understand very well and we learn that we don't divide the sirolimus or paclitaxel, but we learn call single DCB for name. Because, for example, I use a solution, is a technology particular with a cat in the drug inside to the small sphere to allow the penetration. If you use a sequence please or prevail, it's very important to define very well the type of the balloon, the type of drug, and the type. Nevertheless, I don't believe the differentiation into sirolimus or paclitaxel, but in the future, probably we use the typical balloon and typical balloon, because sometimes there is two different, same drug, but the differences is very, very high. This is my comment. In my mind, in Europe, my favorite sirolimus is a solution. My favorite paclitaxel is a prevail and the sequence please, honestly speaking.
Good, thank you. How about your opinion, Dr. Han?
And I think it depends on the results of our clinical trials. Usually we use paclitaxels. We have much more experience about how to use it and what's the result. But for the drug-coated balloon with sirolimus, maybe we need more clinical trials. Maybe I think we just as mentioned by Professor Galli, and a special balloon and encapsulated in the polymatrix sometimes, and it just depends on the clinical trials. We just to see.
Thank you.
But so, I agree completely. We don't tell DCB and sirolimus, we tell this type of DCB, and we compare the data of this type with the data of this type.
Good. Thank you.
Now to move to Dr. Helen Routledge regarding Helen, please show to your result and your slide.
Good morning. Hang on, I'm just going to go backwards on my slides 1 moment. Hi, good morning. Can you hear me okay?
Very well.
Good. Okay. So thank you for inviting me to show some complex cases. I wanted to just show a couple of cases where scoring and cutting balloons had got us out of real difficulty with fibrosis. And I think nowadays we have lots of options for calcium, and when it's a very calcified lesion, we have lots of choices. When it's a very difficult fibrotic lesion, there are fewer choices. And in the past, we've had cutting balloons, which have been very difficult to get to a difficult lesion, and scoring balloons, which we weren't sure how much they were doing. And I think now we have more options, and I'm starting to use these balloons a bit more. So just two cases to show you. The first patient is Mrs. R, who was a 67-year-old lady. She already had a long cardiac history, so she'd had an inferior MI 13 years ago, and she'd at some point had an angioplasty to a right coronary artery CTO, and that had been done a long time ago as a retrograde procedure with lots of stents that you'll see. And she had moderate left system disease at the time. She used to smoke, pre-diabetic, probably familial hyperlipidemia, hypertension, and high platelets. And she presented this time with really difficult angina, so 3 anti-anginal medications at maximum tolerated doses, and she was still getting angina on very minimal activity. Her ECG showed left bundle, her LV function was borderline good. So she was listed for a repeat diagnostic angiogram, which you'll see here. So she had no right radial to access. We went from the left radial. Everything was a bit difficult already. And in the left system, you can see there's moderate diffuse atheroma everywhere. We were slightly worried about the ostium of the left main and whether there was something more important going on there. The distal vessels become quite small. The LAD was okay, but small distally. And you see the left main here from a different angle looks okay, but every angle gives you a slightly different picture. So the right coronary, you can see there's a long stented segment from the previous CTO procedure, and there is critical restenosis at the ostium, and it's pin tight, and we couldn't get even a diagnostic catheter really to sit in there, although you could opacify. And there's still a big distal vessel. The rest of the stents are all okay, but as usual in the right, it's the ostium which has restenosed. So we discussed her in our heart team meeting and decided we should assess the left main stem to see if it was significant. If it was significant, then probably she should have bypass surgery. But if it wasn't significant, then we would go on and do the right coronary artery restenosis angioplasty. We all felt that a femoral procedure in this case might be preferable because no right radial, and from the left radial, it was all difficult to access. So she came on a list for a pressure wire, and then to proceed if this was negative. So left femoral access, pressure wire to the left main and LAD was all negative. Pressure wire to the circumflex and left main was also negative. So we had no choice. We'd agreed to proceed to the right coronary artery. We tried an AL.75 guide. That wouldn't go anywhere near the lesion. We tried a JR4 guide. That would sit somewhere near the lesion. And we could not get any guide support to try and cross this pin-tight ostial restenosis with a number of wires. We tried a workhorse wire, hydrophilic wires, 3-gram wires. And in the end, I thought we should try an angled microcatheter, which did work and let us get a wire into the lesion. But every time we got just into the lesion, everything would prolapse out. So by then we were fed up and tired, and we decided to stop and put this lady on a dedicated CTO list where we would have more time and another thought about how to do it. So she came back on a CTO list. This time we thought maybe left radial would be easier. We tried a XB RCA guide, an AR1 guide, a hockey stick guide, an AR guide with a heart rail in it. We still couldn't get anything to point at this ostial right coronary lesion in order to get us to cross it. So we eventually went back to a standard JR4 guide and managed to engage, but couldn't get any support. So we went back to the femoral approach. Again, a JR4 guide, and this time we tried my supercross trick with a 90-degree angled microcatheter and finally managed to get a standard wire to cross the lesion. And it really wasn't that the lesion was calcified, it was just the angle of the guide catheter. So finally we managed to cross. We used a small scoring balloon first, which we had difficulty crossing with that scoring balloon. But we managed to, but didn't feel it had done enough. So we then took our wedge balloon, 3.5mm balloon, and that actually was very pushable. It crossed easily, it didn't slip, and seemed to have a good effect. You can see the wedge balloon on the right dilated there. And as in the previous presentation, we absolutely didn't want to put any more stent material in here. So we went with a drug-coated balloon, a 3.5 by 20, which I think gave good expansion angiographically. And IVUS afterwards, minimum stent area of 6.4. We felt we'd done as much as we could. I'm not sure whether it's good enough. I am pessimistic that this might come back, but I'm not sure what else there is with that constrained area and stent that we could do. So the learning points for us were the different mindset. If you're on a CTO list and you feel you've got all day to tackle this lesion, you're more likely to succeed. Some thoughts about access routes for ostial right coronary arteries and guide cath support. And really the tendency of the ostial right coronary artery to re-stenose. And in our experience, if you put another layer of metalwork in there, it's not going to help. So probably a drug-coated balloon strategy is good, but I'm not sure whether it's enough and whether actually, even though we don't think of the ostial right as an indication for surgery, maybe we should do more often because this lesion will come back. So that was my first case. The second case, again, fibrotic and ostial, and this is the theme. So this is a 74-year-old lady with a BMI of 32, so slightly challenging. She'd had a stent to her LAD in 2006, and she'd then had further disease and had had bypass surgery in 2007. So there was some difficulty, technical difficulty at the time of surgery with the lemur, so it wasn't used. And instead she had a vein graft, which went from the LAD with a jump graft to the diagonal and a vein graft to the right. And actually, despite just veins, she'd been well for 14 years, but she did have some chronic kidney disease. She then developed severe aortic stenosis in 2021 and had a TAVI. And unfortunately, then she presented back to us with stable angina in 2024, which we tried to treat with tablets. But she came back with less stable pain at rest, and a positive troponin in 2025. So we were obliged to look with an angiogram, which you'll see we found an occluded native left system, which was occluded because of in-stent restenosis in that original 2006 graft, stent which had led to the bypass surgery. And we found a patent vein graft to the right. So the TAVI was unfortunately a core valve, which all of you will understand why we were unhappy to see that. We did manage to see the native circumflex, which was open and didn't have anything significant in it. And we saw the vein graft to the right coronary artery, which seemed to have good flow to the distal right. So the pictures looked like it was quick and easy, but it wasn't. And then we found the vein graft, which you'll remember is supplying the LAD and diagonal. And there's critical ostial narrowing of the vein graft. So we did stop, and we'd been going a while and took her off the table to think, but actually there are no other options really. This lady's got a tight stenosis covering the veins to the left system, the LAD and diagonal. There's no other option for her than an angioplasty. So again, it was hard to engage. We ended up with an AL3 catheter via the right radial artery this time. and a hydrophilic wire, which we managed to advance a Corsair microcatheter around that first bend and get a hydrophilic wire down the vessel. But again, it was fiddly, as you can imagine, quite awkward to get things into that osteal lesion. So taking a normal balloon down helped us to engage that AL3 guiding catheter so that we did have some support to do other things to this lesion. Thankfully, we could then see what we were doing with an IVUS catheter. And this showed us very fibrotic and a little bit calcified lesion at that osteal graft. And it's interesting, you always think of grafts as having benign, soft lesions, but they often are calcified, and in this case was very fibrotic. So we used the Revo Edge as our first balloon here, thinking about the high pressure and the cutting balloon, and that we really wanted something that was going to work first off, and we didn't want to fiddle around with this lesion for too long because of the difficulties with the guide catheter. And this balloon crossed easily, which was great, and you can see the result here. So you can see that we went up to 13 atmospheres, we inflated 3 times, and we got really good looking balloon expansion, at least angiographically. This is the result of the lesion after, and the IVUS images, which won't run on here, so I've left them off, show very good lesion expansion after the Revo Edge balloon. So we then felt we should deploy a stent here. We didn't want this to come back and have to go in again. And we deployed a 3.526 millimeter stent up to 19 atmospheres. And then a non-compliant balloon. Again, 3 inflations up to 19 atmospheres to really be sure that we're not coming back here again, we hope. And you can see there are really good results in that osteal graft to the LAD and doing its job to the diagonal. So the learning points is the awful pain of doing post-TAVI PCI, as well as somebody who's had grafts as well. Vein graft lesions are not benign. They can be calcified. They can be very fibrotic. And I think the use now of what we've got is much easier to use cutting balloons in osteal lesions as well as in stent restenosis. And it seems that the cutting balloons in vein grafts work just as well. So the fact that we can use something with high pressure, with controlled dissection, with this double layer, and still be able to cross and get into the lesion that we're dealing with was really the learning point for us with this case.
Fantastic case in the vein on gray graph. I don't try at the moment, and the next step I try. Thank you for the show the case. So it's because I believe that it's very important, the point. I don't believe that the cutting is the specific device for the high calcific lesion, but for the mixed or fibrotics and calcific lesion is a very, very good choice. Fantastic demonstration. I appreciate it a lot.
Thank you.
Professor Fu, if you want to continue to comment.
Yes, it's really nice 2 cases. I think it's because both are really special situation. First is post CTO and stand to the osteum, and also the guiding catheter is very, very difficult to engage. And the second is post TAVR and CABG, and also the osteo of vein graft stenosis. I think it's for the second cases, I have a little bit of comments, since I think we talking about a lot about the CABG is much better. The long-term result is much better than the PCI, but actually the surgical technique is very, very important. It depends a lot, different surgery, what he did. I think it's very important, especially for the sewing technique of the vein graft to the aorta. I personally think it's not because of the degeneration of the vein graft, but also because of the sewage technique. Depends of this kind of lesion. So it's usually it's very tough and a really hard disease, really high fibrotic stenosis. So I think in these cases, Dr. Routledge, did really good job. I think used a very special cutting balloon to open these osteo lesions. But I in mind these kind of lesion usually they have a little bit much higher stenosis later than the routine de novo lesion. So these kind of patients should be follow up in the next year and see what happens. And if there's and then it will be good for our patients. Thank you very much. It's very nice.
Thank you.
So any comments? It seems Dr. Galli is on the table, something like that.
So, and
thank you again.
Okay, and Professor Fu, I have some comments for this patient.
Please, yeah.
And Professor Ru and has presented two very nice cases and very two special cases. And sometimes for this patient, communication is very difficult to engage the guiding catheter to the osteo of the right, both the right coronary and the left coronary. Maybe, and for especially for the first patients, and because of the stents is protrude to the osteo RCA. So, and sometimes we choose Judkins left. Judkins left, 3.5 or just Judkins left 4. The guiding catheter maybe work sometimes, and when the guiding catheter and closed to the orifice of the right coronary, then we choose one guide wire, very hard guide wire, to puncture, and then fix the guiding catheter to the proximal. And then we choose another guide wire and to open the CTO, maybe from the outlayer, from the struts of the stent, opened again. And then,
yeah, that's a really good tip. Probably that's the one guiding catheter we didn't try was a Judkins left, but I hadn't thought of that. But yeah, it's that difficulty, isn't it? That if you think the stent is hanging out, are you trying to get your wire through a strut, or are you trying to get your wire through a lesion, or do you even have a choice that you just want your wire to go somewhere? So, but yes, I hadn't thought of using two guide wires, one to try and secure it and one to penetrate the lesion. That's a really good idea. Thank you.
Other question for Helen. Okay, thank you so much, Helen, for your share with us your experience. And now we move to the Professor Krissada from Thailand. Krissada Meemook.
Hi.
Please.
Good afternoon from Bangkok, Thailand, and thank you, Professor Galli, for your kind introduction. My name is Dr. Krissada Meemook from Ramathibodi Hospital in Bangkok. Can you see my slide now?
Yes, we see very well.
Okay. I would like to start. I will show two cases today. This is the first case. This is a 65-year-old male. He had a history of the AAA post EVA and peripheral arterial disease with the clinical critical limb ischemia. He also had the diabetes type 2 and also the hypertension. He presented to our hospital with a chronic fluid syndrome presentation with a dyspnea on exertion. You can see the ECG show normal synaptic rhythm without significant ST chain. Because of the symptom, we bring the patient to the cath lab, and as elective procedure, this is a diagnostic procedure. You can see the left choreography show pattern the left main, LAD, and circumference. But you can appreciate the well collateral from the left system to the distal RCA. And the RCA was very dominant. You can see the multiple PLD over here. This is another view on the left angiogram. You can see the well-formed collateral from the left coronary artery to the right coronary artery. On the RCAs, you can appreciate the total occlusion of the mid part of the RCA. At that time, we try to open the CTO. After try for an hour, the operator stopped the procedure because they cannot pass the wire to the distal RCA. This is the equipment that they use at that time. After 3 months, the patient was rescheduled to retry the CTO PCI. Now we calculate the JCTO score. You can see now JCTO score was 3 point. That means very difficult. Okay, this time we prepare the patient use the biplane imaging. This is a diagnostic angiogram. At this time, we use the AL2 guide catheter 7 French from the femoral artery approach, and also we use the contralateral injection from another groin. You can see the occlusion is quite long, like a 2 cm right here, and also diffusely diseased right here. At that time, we try with the anti-gate wiring again with the pilot 50Y with the microcatheters. But you can see after we try for like 5-10 minutes, we cannot cross the wire because I think maybe from the previous subintimal space, so we cannot cross the wire to the distal. So even we change to the Gaia second guide wire, we cannot cross to the distal. But if you look at the left system, you can see the very good septal collateral from the mid RCA to the mid LAD to the RCA right here. So if you look at the global CTO crossing algorithm in the patient with a failed anti-gate wiring, so if we have a very good retrograde option, we should move to retrograde approach. In this case, we use the Zhanying right, not Zhanying blue, Zhanying right with the microcatheter for crossing the septal. You can see we can cross septal without difficulty because the septal crossing is very large. After we cross with the guide wire, you can see the Zhanying Y go to the distal RCA really nicely. And after that, we try to cross the septum with the microcatheters. We use the turntable microcatheters. You can see the microcatheter go to the distal RCA without difficulty. And after we cross to the distal RCA, what would be the option for the retrograde crossing? This is the consensus from the APCTO club algorithm for the retrograde crossing. If the lesion is less than 15 or 20, we should consider the direct retrograde Y crossing. In this case, we try to cross with the retrograde Y. So we use the Gaia second, but we just try to cross, but the Gaia second cannot go to the anti-gate channel because it went to maybe a subintimal space. So right now we have to think about another option. So we use the reverse card. So in this case, we cross the anti-gate Y. But after crossing with the anti-gate Y, you can see the Y crossing right here. We try to do the reverse card at the mid RCA. But we use a small balloon like a 2.0, 1.5, even 1.0 mm. But you can see the balloon cannot go down to the mid RCA, that the area that we want to do the reverse cut. We use a very backup 7 fen AL2, but we have to think for another option. This is the common problem with the CTO PCI. One is we can cross the Y, but another gear cannot follow because of maybe the severe calcification. So this case, I think we face with a balloon uncrossable lesion that is common, like up to 10% in the CTO PCI cases. And also, if we it lead to lower post-op success, and the patient might have the higher the MACE rate, and also we need to use use more contrast, more radiation dose, or the longer post-op time to encounter this problem. What is the solution for the balloon uncrossable lesion? So we have many options. One is we can increase the guide support. So we use the AL2 7 fen. We may use the guide tension, or we can shoot smaller profile balloon, and we can change to smaller microcatheter if we can cross. But in this case, we want the balloon to do the reverse cut. And also the rotational anatomy is not the option for this patient because we cannot go to the distal true lumen. So maybe we use another wine technique, or maybe use like a granuloplasty technique. But in this case, so we just change. We didn't use the guide tension, but we just change to the alveolo high pressure balloon that we have heard from the first speaker that this is a very low profile and very high pressure. I think this is very suitable for the CTO PCI, like in this case, like a balloon uncrossable lesion. So you can see the alveolo balloon can crack the lesion easily to the mid RCA. So we can open up the balloon right here. After 0.75 balloon crossing, this is a alveolo, as we have seen before, very small and very high pressure. I think it's very suitable for the CTO PCI. After that, we can cross with a bigger balloon, 1.5. If you look at this area, you can see even 1.5, even 0.75 cross, but still very fibrotic right here. 1.5 balloon cannot be opened fully. We have to increase the pressure, but finally we can open the lesion nicely. After we use the tour balloon, we use a retrograde crossing with I think as I remember is Gaia second. You can see the Gaia second is can go to the anti-gate catheters, anti-gate guide catheters very nicely. And after that, we just put the Y to the ascending aorta part, and with the balloon trapping technique, we can follow the microcatheters into the anti-gate guide catheter. Right here, you can see the microcatheter can trap here. My preferred choice, I don't use externalization with the IT3 a lot. I love to use the rendezvous techniques. I use the Chiong Y that we use for the septal crossing to do the rendezvous technique. Normally, when we do the rendezvous, we would do at the outer curve, maybe right here or lower. You can see when we do the rendezvous, the guide Y can go to the microcatheters very nicely. And after that, we just finish with the regular PCI technique. We do the balloon and we put 3 stents. You can see we try to cross with PL, but we have some Y induce the PLB dissection, but for it's good, we just leave it. After 6 months, we have the opportunity to bring the patient back to do the control angiogram. You can see the vessel is well open, and also the PLB hematoma now is healed already. This is the final result of the patient. The patient was followed for maybe 4 or 5 years, and the patient has no event. This is another example for the CTO PCI. This is the case of the proximal cap ambiguity. This is another 64 years old male. He has a polyvascular disease, including stroke and also the diabetes with a A1C with a 7.1. He has the parathyroid adenoma post-surgery, and also he present to our hospital because of a CCS presentation with a NYSA class 2 with abnormal ECG. This is his current medication. We sent the patient to do the cardiac MRI. The cardiac MRI show the multiple perfusion defects along the LAD, but the ejection fraction still preserved. Ejection fraction, LV ejection fraction was 58%, and inducible ischemia compatible with the multivessel disease. We schedule the patient to do the angiogram. You see the angiogram show the patent left main circumflex, but on the LAD there was a total occlusion of the ostial LAD. You can see the septal to septal control right here. This is another view. We cannot see the stump clearly. In many angles, we cannot see the stump. This is the RCA. RCA has disease and the distal bifurcation. And also the RCA gave the good control to the mid to distal LAD. This is another, you can appreciate the very good control from the RCA to the LAD. In this case, we have the patient with a triple vessel disease with left main equivalent, and the CMR showed the last area infarction. The calculated the syntax score was 29 and syntax score 2 for the PCI was 30, for CBT was 25. J0 score was 3, and the low ST score. But the patient denied the open heart surgery, so we perform the ad hoc PCI of the ostial LAD CTO. But the problem is we cannot see the stump clearly. If you look here, we cannot see which would be the native LAD, maybe A, maybe B, or maybe C. Right here, this is the cartoon show the IVAS guys, real-time IVAS guys. This is the pathophysiology of the proximal cap. This is the hardest part of CTO. Sometimes we cannot puncture the proximal cap with the normal tools. If we look at the CTO global crossing algorithm in the patient with a proximal cap ambiguity, we may try, if present the side branch, we may try the IVAS real-time IVAS guide to identify the proximal cap and with the anti-gate wiring. Or if we fail, we just change to retrogate wire technique. This is we use a dual injection and also the 7 French sheath and guide catheters. We put the workhorse wire into the septal or diagonal, and we try to use the IVAS guide entry cap punctures. First, we put the wire to the diagonal, and we cannot see the proximal cap, so we change to put the wire, the Zhanying wire, into the first septal branch, and we put the IVAS catheter, the optic cross IVAS, to the septal branch. On the septal, on the IVAS, we can see the proximal cap right here. So we have 2 options. We just remove the IVAS catheter, put the dual lumen catheter, and try to puncture. But sometimes it's difficult. But I think the better option is to use the real-time IVAS guide puncture. So we use the 7 French catheter. So we need to have we need the very low profile micro catheter that we can put together with the IVAS catheter into the 7 French 7 French guide catheters. So in this case, we shoot this 1.7 French Pronavi micro catheter with the pilot 50 wide. So this is a very low profile micro catheter that we can put together with the IVAS in regular guiding catheters. We use the IWAS real-time IWAS to identify the proximal cap. You can see this is the pilot 50 Y that we use the real-time IWAS guide. You can see the guide Y is in the lumen, the LED lumen. This is the profile of the ProNavi microcatheter. This is very low profile. I love to use the 1.7 French microcatheter. This is the breathing catheters. You can talk and push and can track to the torsion lesion very nicely. For the real-time IWAS guide proximal cap puncture, there are 4 essential steps. One, we need to identify the proximal cap with the IWAS and confirm the location of the proximal cap. Two, the wiring technique, we have to choose appropriate wire and technique to navigate the cap. And also, if we puncture somewhere, we need to confirm the wire position. The wire would be inside the medial of the vessel. And the final, we need to advance the microcatheter over the wire to secure the position, and after that we can change the wire to which one that you love to use to encounter the lesion. So we just pushing the ProNavi, and finally we change the Pilot 50 to the Conquest Pro, and now we can cross the wire to the distal to lumen. After that, we use a small balloon to balloon to dilate the vessel. After predilation, you can see something is not correct right here. You might appreciate the linear intraluminal filling defect inside the LED. So we thought this may be the suboptimal wiring, maybe true, false, true. So we put the IWAS into the LED. You can see this distal to lumen. We were in the distal to lumen, but it's when we pull back up to here, we went to suboptimal space right here, and the suboptimal space is very long. And at that area, there the big septal and also the big diagonal. If we put the stent, we will close all the septal and the diagonal, and up to the proximal part, we went back into the 2 lumen right here. We have the suboptimal area right here. This is the IWAS finding. Right here, we're still in the 2 lumen, but start from here. After the big diagonal, we went at the diagonal, we went into the suboptimal space and the distal to lumen, and we went back to the distal to lumen right here. This is very long suboptimal space. If we stem, we would close the septal and diagonal around here. What would be the option to encounter this? So we use another time we use a real-time IWAS guide VNT also. We put the IWAS catheter into the diagonal branch, and we can see the Y into the 4 lumen right here. So we use the 3rd Y. We try to wiring into the left LED 2 lumen. Finally, we can put the Y using the real-time IWAS guide into the 2 lumen right here. This is the wiring step. We try to wire to different position with the suboptimal Y. Finally, we can go down to the distal 2 lumen. Now we're checking the IWAS. We confirm the Y along from the distal to the proximal LDU was in the 2 lumen right here. You can see another Y was in the 4 lumen. So finally, we put the stent to the mid LED, and because of the big hematoma propagate into the big diagonal, so we don't want to lose the big diagonal, so we need to do the bifurcation stenting right here. We do the decay crush technique. This is the decay crush technique at the mid area, and we finally put the 4th stent from the left main crossover to the proximal area with the kissing balloon. This is final result. of the after post stent. You can see the stent was well open from the left main to the distal LAD, and also they will show the well stent position and expansion. This is the IVAS. You see the screen. This is our learning from 2 cases. And in the osteo LAD CTO needs special attention, like we use IVAS, real-time IVAS guide wiring. And also, as I showed 2 cases, sometimes the Y cross, but another 2 cannot cross. We need to increase we need some more tool. I think the very low profile balloon, like an RVO high pressure, 0.75, or the Pronavi microcatheter 1.7 bench, can facilitate the CTO crossing in situation of the balloon uncrossable CTO. And also, I think nowadays IVAS is very important in new CTO algorithm. The IVAS guide integrate cap puncture is essential in ambiguous and blunt proximal cap. And also, we need to prepare for the complication and learn how to manage it. And I think real-time IVAS guide to lumen VNT is useful in case the Y is went in the suboptimal space. And we need to minimize contrast injection because IVAS guidance stent placement can guide where we should be put and what stent size should be shoot without needing the injection of the dye, because we don't want to expand the hematoma. Thank you for your attention.
Thank you, Krissada. Do fantastic cases into the CTO program, and I believe that this company has have a lot of material on for this particular procedure in terms of the profile, in terms of the only a short question, which is, in your opinion, what do you think is the role of the space of the Revo edge to prepare the CTO CTO vessel, especially to avoid a long metal, to reduce the number of stent, to after the distal portion after the reopening, to prepare in DCB or other strategy. Which is your opinion?
Thank you for your question. I think this case was performed very long times ago, but now we have the case with the ADR case more frequently. So after we learn to do the ADR case, so we have to learn how to manage these intramural hematoma. Nowadays we don't put very long stent. If we have very long intramural hematoma, we try to use the cutting balloon first to make the re-entry, and we can reduce the number of stents, and we don't put the very long. I think the scoring and or cutting balloon has small role in preparation of the CTO. And also nowadays we try to prep balloon more preparation in CTO more aggressively, and we use the less stent. We just use the preparation with the cutting, scoring, and if we prep the lesion nice, well, and we use just DCB. So like you said, we just use the stent less and less. But this is back in maybe 5 years back, so we put more stent. But I think if we do this case nowadays, we just use maybe just add the CTO part, and after that we just use the cutting balloon and followed by DCB. So I think this may be the better option. That's my comment.
Thank you. Brad, other comment regarding this case or a suggestion to use this particular device by panel?
Yeah, I have a question. So now that you have the kit to allow you to do the real-time IVUS crossing, and you've worked out how to do it, which we've been wanting to do for a long time, how many of your CTOs do you think you'll use real-time IVUS in? Wouldn't it make it easier for all CTOs? Or?
Yeah. I think I'm a fan of the antigrade crossing. We try to do more antigrade. If we have the ambiguities of small cap, we try to use if we have the Cybran, we try to use the real-time IVAS guide puncture personal cap first before the retrograde Y. And also we use the more ADR technique now. If we put the Y into the suboptimal, we do the balloon to open up the suboptimal space. We just put the IVAS into the suboptimal space and we do real-time re-entry of the CTO. That is my practice now. We try to do more antigrade right now. Thank you.
Fantastic, thank you.
So regarding this is an open question. Regarding your experience, I do sometimes imaging, but I have a lot of experience of Rebo edge and imaging. But a difference of the cutting balloon, repeating a small experience, I don't observe a scene of direct cutting, but I see a controlled dissection. This is your sensation, your feel, or you see other imaging after Rebo edge with IBUS or OCT?
I'll explain with the scoring of cutting balloon. I have seen same with you. We have seen more control dissection. And because in the past, we just use a very high pressure NC balloon up to 30 atmosphere. We found that the patient, the vessel has more dissection and might cause another problem. But with the control dissection, with the scoring balloon like a Revo S, it might have less complication, less dissection, and more control dissection, and might and you don't face much with propagate hematoma like that. I think it's a good option to use the control dissection balloon like a Revo H.
Dr. Zhanying or Helen, do you have any comment regarding the impact, the imaging evidence of the action of the Rebo edge?
Yes, I have a short comment. I think the CTO cases, CTO PCI always very challenging. And these two cases is very nice and a very good result. Not only very high level, but very high quality CTO PCI. To my understanding, my personal also really have very large, huge volume of CTO PCI, including me and my colleague. I personally think the CAS lab should be well equipped. You need all kinds of tools to help you to finish very complicated CTO cases. Not only the support the whole PCI system, but also you need a lot of different kinds of wire and different kinds of micro cassette. And it's also very important, you need a very high quality of CTO balloon is also very, very important. So I think these two cases are very good, very nice. Thank you.
Thank you so much.
Helen, do you have any comment regarding the imaging evidence of the action of the Rebo edge?
I've only seen 2 or 3 cases post-imaging, and I think you can definitely see that there's modification. I've used it more in the fibrotic cases, so there's definitely modification of the plaque, which is visible, modification of fibrosis, but more just with a single balloon, without doing a lot of work, you seem to get vessel expansion quite nicely.
Okay. Okay, we learn a lot of cases to understand well the action. Probably the impact on the plaque is more similar to the scoring than the cutting, but we need evidence in different a lot of cases in different type of lesion, calcified, fibrocalcified, very high calcified lesion. And also in stent restenosis, where I think that is another important thing. Okay, now I appreciate a lot the patience of Professor Hussien that learn all cases, but last but not least from Emirates, Professor Hussien, for you, what do you want? Please.
Thank you, Dr. Galli, and I'm glad to be here with this distinguished group of experts. And I'm also glad to be the last speaker because I get the largest number of audience. I think we have now more than 2,000 attendees, so warm greetings for all of our attendees from all around the world. So in the coming minutes, I'll be sharing with you part of my journey for PCI and how I shifted from the majority of stents to the majority of drug-coated balloons. For now, been using drug-coated balloons for more than 10 years. Now they have become the main device that I use in my interventions for any vessel that is 4 millimeter or less, long lesions, diffuse disease bifurcations, a big portion of in-stent restenosis, where we still keep stents for those left main disease, those with large thrombus burden, osteal lesion, some of the in-stent restenosis, large vessels, and of course, if lesion modification fails. And the whole essence of balloon angioplasty, regardless of drug-coated balloon or stents, is on lesion modification. You need to modify this atherosclerotic atheroma living in the vessel wall so that it does not produce more events in the future and it does not encroach on the lumen. And after we do lesion modification, we assess the outcome. If we have a residual narrowing less than 40%, when we have distal flow of TIMI3, or we have a controlled dissection, and we'll discuss the 33-30 rule, then we can definitely proceed with drug-coated balloons. If not, then we must consider stenting. And I was glad that we published our editorial in the American Journal of Cardiology about our understanding of the sections in drug-coated balloon angioplasty. And this 33 rule, where we have a dissection where there's no persistent contrast staining for more than 30 seconds, and we have a grade TIMI3 distal flow, and a residual stenosis that is less than 30%. When we achieve the 33-30, then we can definitely live with the dissection. It's probably more useful on the long term, and go ahead with the drug-coated balloon strategy. So what tools do we have for lesion modification? We have non-compliant balloons, high-pressure balloons, scoring, cutting, and of course, different atherectomy, including IVL. And today my topic is going to be on scoring balloons because they fit more, as I will show you, into those lesions that do not respond properly to an NC balloon, not essentially densely calcified lesions where we go to more aggressive tools for modification, but also for large vessels. Because I know that probably the weak point now that we have with drug-coated balloons is for the large vessels. We have some evidence, it's not the best evidence, but probably one of the weaknesses is that we're not modifying the lesions properly when it comes to the large vessels. So I've been using some scoring balloons since quite some time. And the nice thing about the scoring balloons, if we look at the work by Bonaventura and his colleagues, they show that when we use scoring balloons, then we end up with having a very low target lesion revascularization rates of around 3%. And most interestingly, that there was no difference between calcified, non-calcified, small versus large reference vessels when we use scoring balloons. And that's what I'm going to try to show you in the few cases that I have selected. And I've been using other scoring balloons, and I was recently introduced to the wedge NC balloon, and I've been using it frequently in the last couple of months. And the two interesting features about the wedge balloon. Number one, the pushability. It has a very low profile, so going into any fibrotic lesion is not going to be an issue at all. And the other thing is that the rated burst pressure is 22, which is along the higher end of when we compare it to other scoring balloons that are available in the market. So it gives you the advantage of having the scoring element. So it creates a focused dissection in the plaque And at the same time, you'll be able to go to a pressure of 22 atmospheres when we're using up to 4 millimeter scoring balloon. So you combine the high force that is exerted by the high pressure, as well as the controlled dissection that you need so that you can tolerate the dissection, and you go ahead with the drug-coated balloon strategy. So without a lot of theory, we'll go directly into the real life cases, starting by this gentleman, and you will see that the majority of my patients are relatively young. Here, where we live in the Middle East, the average age of having an acute coronary syndrome is 10 years younger than what we see in the Western world. So this is a 38-year-old male, so he's less than 40, and he already got an inferior myocardial infarction 10 months before I saw him. And you can see here that the occlusion was in the circumflex, and there is some bifurcation disease in two posterolateral branches. And the operator in another hospital tried to avoid tackling the bifurcation properly. So he placed the stent, and he probably missed the side branch, and he missed a significant lesion proximal to the bifurcation. Anyhow, the patient remained good for like 8 months, and then he started again to complain of chest pain with a positive exercise test. So we took him for an exercise test that was positive, and then we went for the angiography, and you can see here that we have a significant lesion proximal to the stent that was deployed in the circumflex. And that tells you that you have to respect the bifurcations. Escaping with a stent and not going back into the main vessel and doing the proper pod, as Dr. Galli said, would definitely run you into trouble. So we have a lesion that is proximal to the stent, and it's also involving a bifurcation. So what we did is that, of course, we went by an intravascular ultrasound to try and understand what was happening. So this is the IVUS pullback. We see the stent distally, it's well expanded. There's some under expansion here. And then we'll see that the stent definitely missed a significant lesion at the bifurcation. So here you can appreciate the significantly reduced lumen. So we went ahead, we used a regular NC balloon into the main branch, 3.0 by 25. When I use DCBs, I tend to take longer NC balloons. And we used a relatively shorter balloon for the side branch, a 15 millimeter NC balloon. And we assessed by IVUS again the main vessel. And you'll probably notice here that we got some expansion of the stent, but more importantly, we got also a significant improvement in the minimal lumen area compared to the pre-intervention IVUS pullback. So you'll see here that we got a significant improvement in the minimal lumen area. And so initially we had a good result with both the main branch and the side branch, but when we use DCBs, we like to wait for a few minutes, on average 5 minutes, and we see that we had some recoil in the side branch with the non-compliant balloon. And then so we had to escalate for a more aggressive balloon or a proper balloon. So you see the minimal lumen area in the side branch after the NC balloon was 2.7 millimeters square. So we went ahead and we used the wedge 2.75 by 15. And as I told you, the advantage of the wedge balloon that you can go up to higher atmospheres than 20 atmospheres. And this is the result after the wedge balloon, and we confirmed the result with the IVUS. We were able to get a very sufficient lumen in the side branch. So we were able to execute our strategy for drug-coated balloon in a bifurcation. We took a 3.0 by 35 sirolimus for the main branch and a 275 by 30 sirolimus for the side branch. Of course, when we're doing a bifurcation with DCB, we tend to avoid kissing drug-coated balloons for many reasons. And you can see here the final result in the right oblique projection and in the left oblique projection. We ended up without adding extra metal to a place that already had a stent, and we ended up with a good result in a bifurcation, preserving the integrity of the carina and both side branches. So that was the first case. The second case was a STEMI. You see here again, we in our region we have relatively young patient. That's why we like drug-coated balloons. This is a patient who presented with a STEMI of 2 hours chest pain. The cath lab activated, and we see here the thrombotic occlusion of the right coronary artery. And once we crossed with the wire, here we didn't do any ballooning. The lesion opened, but we had some reduction of the distal flow, TME2 flow, and with some bradycardia, probably a reperfusion arrhythmia. So in ST elevation myocardial infarction, the evidence for DCB is there, but it's not as good as non-ST situation, a non-ST elevation MI, and of course with chronic stable disease. So in that situation, we went directly and deployed a drug-eluting stent directly across the lesion. We chose a 4.0 Biolamus drug-eluting stent, and with the stent enhancement tool, we confirmed that the stent is properly expanded into the lesion. Then looking at the control angiogram, the RCA showed more disease than just the stented lesion. And we made sure that it was not a spasm by disengaging of the guiding catheter. And after injection of nitroglycerin, we discovered this significant narrowing in the proximal RCA. And as shown by one of the previous speakers, the proximal RCA and near the ostium of the RCA is one of the notorious situations where you get instant restenosis that is difficult to treat. So we went with the same balloon of the stent. It was a 4.0 balloon, and initially it appeared to be well inflated and well expanding in the lesion. And when we initially we had a relatively good response, but again with DCBs we have to wait for a few minutes and check that there is no recoil. And this is the image after just 5 minutes. You see that despite an initial good result, we ended up with significant recoil. So if we want to do DCBs and try to avoid stenting of this part and ending up with a long stent, then we went with the wedge balloon. And as you see, we managed to do it exactly at the lesion without significant slipping. And that's one of the advantages of the scoring balloon. And these scoring elements tend to anchor the balloon in the plaque. And I like to inject while the balloon is inflated so that we make sure that this is the right size of the balloon. It was a wedge 4.0 by 12. And this is the result after 5 minutes of waiting. You see that the lesion now is stable with no recoil. And then we were able to go with a sirolimus eluting drug-coating balloon 4.0 by 25. And here's the final result. So the stent is great. And we avoided putting an extra metal and extending into the paraosteal lesion of the right coronary artery, thanks to the proper lesion modification with the wedge balloon. The last case, for the sake of time, is for a acute coronary syndrome in a large vessel. And again, you see the majority of my patients are young, with lots of risk factors, diabetes, hypertension. Here, the gentleman presented with acute chest pain with significant elevation of troponin and an ejection fraction of 40%. And the angiogram is clear. We have a severe stenosis of the proximal LAD. And the proximal LAD here is a large vessel. And so we learned from the previous cases that when you're having a large vessel, you can go with an NC balloon. But if you want proper modification, if you want to save time and you want to save devices, the plaque burden in the large vessels is significantly bigger. So it's good to go with a scoring balloon from the beginning. And that's what we did here. We took a wedge balloon. We took a 4.0 by 12 wedge balloon. And I always like to inject when the balloon is up to make sure that this is the right size of the balloon into the LAD. So we inflated the wedge here 14 atmospheres, and then you see the marvelous result just with a couple of inflations with the scoring balloon. The LAD, now there's no significant dissection. We gained a significant lumen, And we waited for several minutes to make sure that there is no recoil. And you see here the marvelous result just with a couple of inflations with a wedge scoring balloon. So we had no doubts, and we went ahead with the IVUS to make sure that we had a good lumen. I know that the role of IVUS with drug-coated balloons is still not evolved, but I tend to look into the minimum lumen area. If I have a good minimum lumen area, like here, it's more than 7 millimeters at the site of the lesion, and even larger at the distal part of the lesion, and much good and much better in the proximal to mid LAD. So we had no issues with going with a paclitaxel 4O by 30 drug-coated balloon, inflated just at nominal pressure. And here is the final result in both projections. You see the LAD is patent, TIMI3 flow with no significant recoil and no significant residual narrowing, at least angiographically. We know the plaque is going to stay there, but we hope that the effect of the high pressure inflation with the scoring element and the drug would induce positive remodeling on the long term, so that the plaque shrinks or at least maintains its size and doesn't encroach enough on the lumen. And you see the baseline echo of the patient showed significant wall motor abnormalities in the apical LAD. This was before the procedure, the next day of the procedure, and 1 month after the procedure. We stopped the habit of bringing patients after doing a DCB to do a control angiogram because we see very good clinical results that are supported by the ECG and the echo. So the conclusion is scoring wedge balloon is a good device for optimal lesion modification and control the dissection, considering the high pressure that you can go, the low profile, the deliverability, and it helps us to succeed in the strategy of leaving nothing behind or reduce the amount of metal, even when we're dealing with larger vessels, even when dealing with proximal LAD and proximal RCA. Thank you so much.
Thank you so much. I appreciate a lot, not only the presentation, Hussien, but I want to meet in person, because I believe in your completely idea to, is possible, reduce as soon as possible the metal. And now I do two particular questions.
Sure.
When in acute coronary syndrome, especially in ST elevation MI, my feel, but isn't, I ask to you, is for your feel, the lesion preparation, if you want to move to the DCB approach, is completely different. So it's big difference than the standard stable patient than when you use. So do you believe that in acute coronary syndrome we need to prepare in different way, and which is the role of the scoring in this is different than in a chronic situation, elective situation, or not? First, and then the second.
I think the main issue with acute coronary syndromes, or a big issue, is the thrombus. So the thrombus poses two problems. The first problem, the more you try to modify the plaque or the atheroma, the more you run into distal embolization, which you want to avoid, of course. So that's the first problem with the thrombus. The second issue with the thrombus is it may hamper the delivery of the drug into the vessel wall. To avoid that, you need to do good modification, but if you insist on multiple attempts of modification, NC, scoring, cutting, etc., then you will embolize more. So if we manage to minimize the thrombus burden with the thrombus aspiration, with a good antiplatelet, or even if the thrombus is a benign one that responds nicely to a semi-compliant balloon, then I would proceed for a drug-coated balloon strategy. But if the thrombus worries me and there's a significant distal embolization, and I'm worried that the more I manipulate the lesion, then I run into trouble, then I throw in the stent directly.
Okay. I'm agree. Another point, in my algorithm, if when you use a DCB, when we don't obtain a good result, I move to the advanced device. Before I use, as you, like you, the scoring balloon. But provocative question. Do you believe that the wedge balloon is so strong scoring, or probably the revo edge is could help to us to more effective to have a controlled force dissection? Do you understand my
Well,
question?
yes, yes. There is no scientific answer for that, but we'll try to improvise.
Absolutely.
Probably the wedge balloon is somewhere in the middle between a regular NC balloon and the rove cutting balloon. And it depends on your assessment of the lesion, how calcified is it. So if it is more towards the calcified side, more than 180 degrees of calcium by intravascular ultrasound, then I will go for the cutting. If just some specks of calcium, large plaque burden, then I will go for the scoring. So maybe imaging can try to give us the answer in that case.
I'm completely agree with you. Professor Fu, other guys, you have any question, comment regarding the presentation of Professor Heshmat?
Yeah, thank you, Dr. Gary. I think it's a really nice presentation and lets us really full understanding about the cutting and scoring balloon in the use of ACS patients. To my understanding, I think especially for the ST elevated myocardial infarction patients, usually it's the plaque rupture. And normally, if the patient have a full lipid plaque and the rupture, and they will usually have an ulcer or kind of kinds. So if we don't touch it, we just leave it, just use the PDCA, just the purple, I think they still have about 50% patients still live very well. So I don't know which kind of patient would be benefit from the drug coating balloon after the lesion proliferation of ST elevated myocardial infarction patients. It's depending on the flow or depending on the image and so on.
Well, it depends on the distal flow. It depends on the presence of a residual thrombus, and it depends on the residual narrowing. So when it comes to modifying the plaque or handling the atheroma in acute coronary syndrome, the atheroma that has ruptured. Now let's forget about the thrombus. Let's focus on the atheroma itself that has an ulcer or something. Now we will do a balloon angioplasty, whether it is a non-compliant, semi-compliant, scoring, cutting, whatever. And so the balloon angioplasty, what it will do, and I'm now going back to the old work of, it's from the 1980s, from plaque sealing by angioplasty. I forgot the name, it's a very famous guy. So what happens is whenever you injure the plaque with the balloon, the body tends to heal, and the healing process would entail the formation of a neo-intima. And this neo-intima is good because we know when we treat in-stent restenosis that the neo-intima is slippery. If you put a regular NC balloon, it jumps. So this neo-intima is slippery and it's resistant to thrombus formation. But if it grows too much because of the injury that we induced by the balloon, then the vessel will get narrowed again. So the aim of the drug-coated balloon is to intoxicate this atheroma with some anti-proliferative drug so that the neo-intima develops, but it doesn't develop too much. So we maintain the thrombus resistant surface without growing too much and encroaching on the lumen. And that's why we still, I believe we still need the drug for the long term in patients with ST elevation myocardial infarction.
So during the routine, our clinical experience, if patients don't stand after the brain PCI, they have some reasonable lesions of patients will be occluded again in very close time. So in your cases, you use the drug-eluting balloon, they have patients how much high instance of closed during the hospital and also on.
Well, in our experience now, been more than 10 years using DCBs. I think we're speaking about the need to take the patient back to the cath lab within the first 48 hours. This happened with me twice in 10 years.
Twice in 10 years.
If I compare that to acute stent thrombosis, which I used to have.
Absolutely agree. Absolutely my
once
experience.
every 6 months or 1 year, even when we use imaging, even when we use OCT, then I'm ready to tolerate DCBs rather than drug-eluting stents. And the theory of plaque sealing by angioplasty is by Bernie Meyer, one of the pioneers of angioplasty since the 1970s and 1980s.
Good, thank you.
I only to comment and then we finish regarding this point. I believe that we need a lot of data regarding this point, and also obviously, and also I believe that the lesion in acute coronary syndrome is completely different than in elective, but nevertheless, the point of DCB in the novice is not only the safety but the efficacy in the long term. For these reasons, it's very important to prepare very well the lesion before to elute a drug. Okay, we are finished our webinar. I hope to meet the purpose of the PROSMED. We share a lot of things, we share a lot of material, and we share where it's possible to apply this technology in what you want: saphenous vein grafts, bifurcation, stenosis, de novo lesion with DCB, CTO, what do you want? And I appreciate a lot your contribution, and a big thanks from me and also from your panel. I finish, Professor Fu, if you want to close the webinar.
You just close it, it's enough. Good, thank you.
Okay, bye-bye, see you.
Bye-bye, see you.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye.